Should I start?
Yes, yes. Yes, Kritika. Kritika, we are live already. You can start.
Good evening, everyone. Welcome to yet another webinar of SIMS JIC 2020. Today we have with us three eminent doctors. Firstly, Dr. Ramesh Daggubati, who is the Associate Chief of Cardiology and Director of the Cardiac Cath Lab and Director of Interventional Cardiology Fellowship Program at NYU Winthrop Hospital. He is skilled in all structural, heart, and complex coronary interventions. He performs transradial interventions and proctored many physicians across the country and world. He was also the former principal investigator of the initial transcatheter aortic valve replacement trials. He has published in multiple academic journals and lectures nationally and internationally. Moving forward, we have with us Dr. Satya Gupta, who was the organizing secretary for JIC 2019 and is the director of SIMS Hospital Ahmedabad. He has done his interventional cardiology fellowship program from Paris, and during his fellowship, he got trained in radial angiographies and angioplasties. He has been invited by the government of Tajikistan to set up a cath lab there and has performed thousands of radial angiographies and angioplasties. He has also been acknowledged by President of Tajikistan for performing radial angiography and angioplasty for the first time in the country. It's great to have you on board, Dr. Daggubati and Dr. Gupta. We also have with us Dr. Vipul Kapoor, who is a consultant interventional cardiologist at SIMS Hospital, Ahmedabad. He is the fellow of European Society of Cardiology since 2014 and has a vast clinical experience in primary angioplasties, complex coronary interventions, peripheral interventions, device closures, pacemakers, and 3D transthoracic echocardiography. Thank you, Dr. Kapoor, for joining us today. Let us proceed towards the videos, please.
See, cardiogenic shock, the management of cardiogenic shock is an art. And in my experience, I can tell you for the past 20 years, it carries a high mortality, and the outcome of cardiogenic shock treatment is directly proportional to the interest of physician or cardiologist who is treating the patient, as well as the family support, both emotionally as well as financially. If three things work together, I think we can bring out, or we can take a cardiogenic patient more properly. So whenever the first principle of managing a cardiogenic shock is, you know your patient, what kind of cardiogenic shock you are, or what kind of shock it is. Sometimes we feel, okay, patient is having LV dysfunction, it is a cardiogenic shock. It may not be. Patient may be harboring some subclinical infection, and we may be ideally treating the septic shock. So you should know what kind of patient you are dealing with, whether it's a hypovolemic shock, whether it's a septic shock, or it's a cardiogenic shock. Even in the cardiogenic shock also, there are different parameters. All cardiogenic shock cannot be treated in the one way. There are different causes. Like aortic stenosis shock has to be managed differently. Patient tamponade has to be managed differently, or severe LV dysfunction has to be managed differently. Definition wise, yes, persistent hypotension less than 90 millimeters of mercury, which is continued for more than 30 minutes, associated with reduce in the cardiac index and increase in the PCWP, is the definition for cardiogenic shock. Most common cause of cardiogenic shock is myocardial infarction. There is a long list of cardiac causes, but yes, the most common cause is a myocardial infarction. And once we deal with the myocardial infarction, you should think positively whether if your patient is not improving, is patient belong to any of this risk category, and then you can manage accordingly. Recurrent ischemia was supposed to be one of the most common causes of cardiogenic shock, but in the present PCI era, most of the patients they undergo primary PCI. So incidence of cardiogenic shock has come down, and this because of reocclusion of the vessel, which can lead to severe LV dysfunction. And one of the autopsy study, it has been suggested that those patients who develop cardiogenic shock, almost two-thirds of the patient has severe coronary artery disease, or at least on all the three vessels. And this is a very pathognomic, like we know everything that because of systolic and diastolic dysfunction, patient develop hypertension, reduce ischemia, and ultimately patient lead to severe ischemia followed by severe LV dysfunction, and patient succumb to death. And these are the common risk factors. Most common risk factors is old age, multivessel disease, anterior MI, ST elevation MI, patient with diabetic, hypertension, prior MI. These are the more risk factor for developing cardiogenic shock. So if you are dealing with this kind of risk factor patient, please suspect that this patient can anytime develop the cardiogenic shock. And as I said, the first principle, you know what kind of patient you are dealing. So is it a really cardiogenic shock? And yes, what is the severity? And then again, you have to rethink whether you are dealing with something LV dysfunction or the RV dysfunction, because again, management will be differ. And what supportive system you have to evaluate. So how to approach a patient with cardiogenic shock? Take a detailed history from the relative, from the patient, because each historical point will give you clue to management of the patient. Examine the patient from head to toe. Check all the peripheral pulse and also assess the pulse volume character, because so many times you will give a good clue from all these things investigation. And assess JVP, its waveform. Assess the heart rate, whether patient is having tachycardia, bradycardia, respiratory pattern. Blood pressure, pulse pressure is a very important thing. If there is a narrow pulse pressure, definitely patient is having high left ventricular and diastolic pressure. Look for LVS3 and look every day. You assess the patient every day. You auscultate the patient. You will definitely will see some new development or heart systolic murmur, and auscultate all the areas of the chest, whether patient is bedridden or whatever. But try to auscultate all the areas of the chest. All these investigations are must. I would say that any patient cardiogenic shock, you have to have blood investigation to rule out any metabolic cause. ECG has to be done on the everyday basis. Chest X-ray has to be done, and not only doing the echocardiography, but echocardiography finding has to be correlated with the current situation. And always assess IVC if you are dealing a patient with the cardiogenic shock. And again, not only investigation, even CVP, PA pressure evaluation is as important as other blood investigation. So all patients for cardiogenic shock, if you want to treat by heart, definitely they should have the central line in the place and assess CVP, assess PA pressure, pulmonary capillary wedge pressure, and the cardiac index on the daily basis. As I said, for the IVC, if IVC is less than 21, it's a collapsible more than 50%. First thing, you give the fluid, because RA pressure seems in this patient is only 0 to 5. And if there is a IVC size is more than 21, still collapsible, then RA pressure looks normal. But again, you can load this patient with some IV bolus. But IVC more than 21, non-collapsible. If you give fluid also, there won't be any response. So it's very, very important how you assess your patient. And when you go to bedside, you see a patient, some patient may be very wet, some patient may be very dry. And out of that, some patient periphery may be cold or the warm. So everything will give you some clue, and manage your patient accordingly. And because pathophysiology is, both kind of patient will be totally different. So how to treat a patient with cardiogenic shock? First, give 250 ml of saline bolus for 10 minutes. Keep RA pressure around 10 to 14. CWP around 18 to 20 millimeters of mercury. Maximize oxygenation. If patient is having hypoxia, put on the BiPAP, put on the ventilator. Discuss with the family, and then definitely you attack a right thing at the right time. That is the key for managing a cardiogenic shock. Give vasopressure, inotropic support. Don't just start dopamine, dobutamine. Just think what pathophysiology patient is having, and accordingly you react. And if patient is having tachycardia, atrial fibrillation, manage accordingly. And correct electrolyte, acid-base imbalance, and phosphodiesterase inhibitor now is easily available. Milrinone, Emrinone. You can take use of that. That transiently improve the patient status. Calcium sensitizer, glucosamine has shown the promising result. So you use drug accordingly, and then your result will be optimized. And then once you stabilize the patient, then think for revascularization. If patient is having hypotension continue, just go for angiography, treat the culprit vessel. If there is a triple vessel disease, just do revascularization, then patient will do very good. Or patient is CABG patient, explain the family, send for high risk CABG and patient will do better. Use vasodilator, diuretic at the optimal dose whenever required. One more thing here about the diuretic, we don't change the diuretic dose. Everyday basis, we have to titrate the diuretic dose in patient with the cardiogenic shock. That is a very important. Think of ECMO impeller device. From morning we are discussing about heart transplant. So you think right thing at the right time, definitely your patient will improve. This is a very good article I have taken from Circulation. In every ICU, I think this picture should be there. Not only the medicine dose, but as well as where this medicine act. I think, sorry. The last one, whether it increases systemic vascular resistance, whether it reduces the peripheral vascular resistance, it's very important when you treat a patient with a cardiogenic shock. And again, like if I'm treating a patient with cardiogenic shock with AR, those patients need tachycardia. I need to increase the heart rate so that I can reduce the diastole and patient will do better. If tachycardia is not, then I can put even the pacemaker, temporary pacemaker. So what you need to reduce diastolic phase so that your end diastolic pressure will increase and patient come out. So cause-specific therapy is very, very important. Whenever your patient is not doing appropriately, then think of all these complications in patient with MI and you will do better or a patient will do better. I'll just shortly brief one patient with the refractory cardiac shock, how I managed this 62-year-old male presented with acute onset of chest pain. He was non-diabetic, hypertensive. He had effort angina for 1 year, but he ignored. His brother had coronary artery disease. And he was rushed to a nearby hospital. His blood pressure was on the lower side. Pulse rate was 54. SpO2 was low. He was put on TPI, diagnosed as inferior MI and CHP, and he was managed. So now, if I manage this patient medically without thrombolysis, mortality is almost 30%. But in the thrombolytic era, the mortality has reduced to 15%. If I do intervention, definitely the improvement mortality is 7%. But if I manage the complication also, definitely I can bring down the mortality to 2 to 3% only. So this patient underwent angioplasty at the different hospital. PDA was occluded and there was residual lesion in the LAD and he underwent angioplasty. Wherever he underwent angiography, result was excellent. There was occluded PDA here. I don't know where is the marker pointer here. This one? Just show me which is the point. So in the PDA is occluded here and who had done the angioplasty has opened the PDA. Excellent result. And you can see the large PDA which was occluded and now it is open fully and excellent result. And what happened now? The patient subsequently discharged from the hospital. He continued on a nocturnal cough and dyspnea. BP was on the lower side and he had one episode of the PND and his dyspnea was not subsided. He would continue to have dyspnea. And this was the ECG, not very much suggestive, but only tachycardia. And patient was readmitted. He had hypotension, was put on IABP, BiPAP support. There was no improvement on IABP support, and patient still continued to have the dyspnea. Echocardiography was done, which was suggestive of moderate MR. So this patient was explained that patient having a dyspnea because of pulmonary congestion, but the family came to me. They wanted MVR to be done at SIMS hospital because they have advised the mitral valve replacement. On the admission, I saw the patient was having atrial fibrillation. BP was on the 80 millimeter of mercury only. Creatinine was high. Everything was not in favorable condition. He had atrial fibrillation, which I managed with IV quadron. I did portable echocardiography, and there was hardly any MR, grade 2 MR. So I was in suspicion why I should subject this patient for MVR. And I managed the atrial fibrillation with the IV quadron. Now the family was behind me that we brought here for the MVR only and you are not doing MVR. There is a problem. But I was not convinced that this patient sending for MVR. Then with the heart team approach, we discussed everything, radiologist, anesthetist, cardiothoracic surgeon, and we even did the CT angiography also. We found out there is some respiratory problem. And I did TE and the TE was suggestive of only mild MR. But what surprisingly I could find out, there is a big rent at the apex. So this patient was having subclinical large ventricular septal rupture, which was picked up by the TE. And so whenever your patient do not respond the way you want, this is the way you manage your patient. I will not go detail about the interventricular septal, but subsequent course patient did very good. He was discharged on the 15th day, and this is a follow-up visit. I saw the patient is doing very well. So the take-home message is managing cardiogenic shock is an art. Proper selection of inotrope, anticipation of different symptom response, and cost target therapy is the key for the management. Medical structural complication has to be managed properly, and early clinical findings, symptoms, investigation finding should all be correlated. And if all this picked up at the correct time, I think it can be life-saving, and your patient can do better, and it will be rewarding.
So this is a case-based study. Here is a 60-year-old male presented to an outside hospital, sudden onset substernal chest pain, and he had hypertension, hyperlipidemia, coronary artery disease, peripheral vascular disease, had bypass surgery, Lima to LAD as well, which was patent from a previous angiogram. All the other vein grafts were occluded. And he had a AAA repair as well as a left fem pop bypass in 2007 and 9 respectively. So when he went to the outside hospital, initial EKG was unremarkable, but because of his chest pain, he was given nitroglycerin. Then patient actually developed more pain and became hypotensive. And then repeat EKG at that time showed ST elevation. So I don't know whether it was iatrogenic in the inferior leads and reciprocal lateral ST depressions. So subsequently, he went into VFib arrest, and he regained consciousness after spontaneous circulation after 20 minutes and of ACLS, still unconscious, and ST elevations were persistent. He was started on dopamine and was given thrombolytics because of the inferior ST elevations, and then transferred to our tertiary care center. So here's the ECG that shows ST elevations. If it is not very clear, this is what we do in our cath lab. As soon as he comes in, we take a 7-lead EKG. You can see there's ST elevations and in the lead, inferior leads, as well as in the reciprocal ST depressions in 1 and AVL. So most important thing here is blood pressure is 80 or 51, 113, and so the question here is, when you see such a patient, how many of you would choose dopamine as first line versus norepinephrine? I'm asking you because that's a specific study which showed that, right? So noradrenaline is the one to do, not dopamine, but so they use dopamine. Okay. So he was on the ventilator. He was transferred to us like that in cardiogenic shock post-cardiac arrest. And here is left coronary artery. Nothing much is left in the LAD. You can see a small circumflex artery and diagonal. Lima to LAD is quite patent, and you can see it's big vessel. And RCA is completely occluded. And but there is a branch that is giving collaterals to the circumflex and probably the left PDA. So here, there's nothing for me to fix at this point of time, right? What should we do? So he had a 6-French sheath in the right femoral artery. We cool them. And how many of you cool patients now after cardiac arrest? Cooling, yes or no? Raise your hand. No cooling? The rest of the people don't cool. So cooling is still good, despite hypothermia protocol, even though it has been shown that people are now getting some confusion. Hypothermia is number one, is very good. But the data that actually confused people is whether 33 degrees or 36 degrees. It didn't really make any difference. So cooling is good, so that don't forget about that. So in this patient, we put in a 14 French impeller catheter and from the femoral sheath and then Swan Gans from the left femoral vein. So post impeller, so I didn't do anything actually. This is about 5 minutes after impeller. His ST elevation started coming down. Remember, there were more ST elevations prominent in this one. So, we started norepinephrine in the cath lab, and dopamine was discontinued afterwards, and just norep was continued for vasopressor support. Okay, slightly different. So these are the slides that was not playing, but you can imagine that here the LV was not doing well. But I'll show you a next one, which actually where it is. So in hospital day 0, his PA cardiac index by FIC is 3.8. Pulmonary pressures were high. Wedge was 31, and he was on dopamine and norepinephrine in the cath lab. And day 1, actually, dopamine was discontinued and PA pressures are slightly coming down. And day 2, much better. Norepinephrine also was discontinued, and which is only 14 now. So he woke up after a few hours in the intensive care unit, and hypothermia protocol was discontinued because he woke up, and everything was weaned off gradually. And echocardiogram on day 2 showed improved ejection fraction. Impella was removed on day 2, and patient was extubated on day 3. So the previous echo that did not show that, actually now its EF is much better. Still, you can see impella is in place. So, and then he was kept in the hospital for 7 days and slowly started on all titrating the medical medications as we could tolerate, as the patient could tolerate, and he was discharged home on day 9. So this is not playing, but the EF has completely recovered now. So what is the reason why we are trying to talk about epinephrine versus norepinephrine is because if you look at it, any type of vasopressor, this is the data from Samuels in 3,400 patients back about 20 years ago. And that actually he said that even one high dose of inotrope increases the mortality by 21% compared to a moderate dose of inotrope. And this was at that time, they done including dopamine as well. So 5 to 10 mics is considered as a moderate dose, and more than 10 is considered as a high dose. And 3 high doses of or any vasopressin will increase the mortality to 80%. So vasoconstrictor strategy is based on blood pressure and does not reflect cardiac output or tissue perfusion. So in cardiogenic shock, please do not think that actually, let me give some inotrope and vasopressor agent, and that will resolve all the problems. And I'll show you why it doesn't. So this is a new chest paper that actually tells you a busy slide. I thought it would be in the bigger room, but you can't see much. What it tells you is basically you have to assess the right ventricular function, left ventricular function, and try to see how can you reduce the afterload both for the right ventricle and left ventricle. And at the same time, you probably push more fluids in the RV failure to increase the RV preload as well, so as to be able to push the fluid into the left side. So, and vasopressor agents here, actually you can see only in the red at a couple of places that they are done. And along with that, they actually tell you that you should consider mechanical assistance wherever there is vasopressors in the red, increased coronary perfusion probably, but mechanical assistance. So that's what mostly we are trying to get away from that and move towards the mechanical assistance. Here, as you can see, you assess RV and LV systolic function, and if the patients are hypotensive and hyperperfusion, then you actually look at their endothelial or organic dysfunction, and maybe it can even cause decreased coronary flow. That's why we have to see. So in a normal patient where the stroke volume is and mean blood pressure are good, in severe heart failure patients, they come to very much lower down, both the stroke volume and the blood pressure low. What happens with the inotropes, whether it is epinephrine or norepinephrine, and this is probably, I'll show you a few slides on the study that actually looked at it. This is a pressure volume loop, and the pressure volume loop actually shifts to the right. Any shift from this pressure volume loop to the right side is actually increasing the cardiac workload, and it is not good. And that's the same thing ECMO does as well. If you just put a patient on ECMO without unloading the left ventricle, you're going to actually make the heart work harder. When somebody is in cardiogenic shock, you don't want their heart to work much more than what it is already doing. You want to give some relief to the heart muscle. So here is cardiac power output. The same thing I showed you. This is a normal, and this is severe heart failure. As I told you, the byproduct stroke volume and blood pressure go down. And this is a cardiac power calculations. In a patient who is normal, the cardiac power is about 1.2. In people who are severe heart failure, the cardiac power is very low. Less than 0.3 indicates that their probably mortality is 80%. So in a people who have good perfusion, you can see the maximum vasoconstriction can occur on auto-regulation happens in these people to improve the perfusion pressure as well as the flow. So that said, there has not been any study until recently and last year where people said, okay, let me look at epinephrine versus norepinephrine. Epinephrine is mostly used by cardiac surgeons. Norepi is used by cardiologists. So somebody said, okay, let's look at that. Out of 163 patients, only 57 were included in this study, and comparing epinephrine versus norepinephrine. And if you look at it, actually, there's not much of a difference between both. The mean arterial pressure is maintained well, and cardiac index is both maintained well, but the heart rate is higher with epinephrine, and the stroke volume is also equal. So because of the heart rate being higher and because it made the heart work harder, patients were in a refractory cardiogenic shock for a longer period of time with the epinephrine as compared with norepinephrine. So the refractory shock was seen more. And so because of what they found in this study, even though in 57 patients, they actually had to stop this study early because patients were remaining in cardiogenic shock, in refractory shock. You cannot keep people in shock and for longer time. Refractory shock is anybody who's in shock for more than 6 hours. So you can't keep them in refractory shock and then try to do all the expensive devices and think that you'll make a difference. Mortality is almost guaranteed more than 80%. So as you can see here, arterial lactate is much higher with epinephrine in the blue, and that goes with the cardiac double product is much higher because of the increase in heart rate, and that is making the heart work much harder than actually norepinephrine is doing. And that is purely because norepi does not have much of a B1 and beta 1 and beta 2 action, whereas epinephrine actually has along with alpha action, it also has a high beta 1 and beta 2 action as well. So in the United States, when we started this National Cardiogenic Shock initiative, we found that people who have high lactate and low cardiac output, the survival is only 30%. So just because lactate is high doesn't mean anything, but if the cardiac output is low, meaning if the heart muscle is working too much, your cardiac output will come down low, and that's what we don't want in these people. Okay. So the shock is a multifactorial. You really want to reduce the workload on the heart, and you want to move the pressure volume loop to the left. So even in people who have ECMO or inotropes, putting in a device that actually can reduce the left ventricular end diastolic pressure is going to be much better than treating actually with just inotropes to increase the blood pressure alone. Thank you.
Thank you everyone for joining in. Our doctors are actually stuck in an emergency and unfortunately will not be able to join in for the webinar, but they will be taking up your questions soon enough and we will be mailing you the replies to all the questions. Thank you so much for joining in.